Breast cancer is one of the significant public health problems among women worldwide. In 1975, Armstrong and Dahl published an article on a striking correlation among countries between national per capita fat consumption and breast cancer incidence. In 1978, Hill's study showed a strong correlation between national per capita total fat disappearance and breast cancer rates, primarily due to animal fat, as the correlation of vegetable fat is lower. While Carroll's 1975 study demonstrates a limitation within the ecological approach, the fat consumption estimates for the United States was 150 grams per day, representing about 40% of calories. Case control studies are the most popular study to examine the relationship between fat intake and breast cancer risk. A meta-analysis investigated 17 case studies on the relationship between total dietary fat and the risk of breast cancer. Even though all studies do not provide a strong positive association between consuming certain types of dietary fat and breast cancer risk, at least a moderate association does seem to exist.
In prospective studies, the potential for bias due to selective participation or differential recall is eliminated for the dietary fat and breast cancer relationship. One early prospective study in Japan in 1978 reported higher incidence of breast cancer among female daily meat eaters, but this was only 14 cases. Later, Phillips and Snowden examined Seventh-day Adventists, and those who adopted a vegetarian diet earlier in life tended toward higher rates of breast cancer. In the first large prospective study of total fat intake, no significant association was observed between fat intake and breast cancer, though it is possible the latent period between exposure and disease was not represented in this 4-year perspective, so the follow-up was extended up to 20 years. Still, no association was found. A 1996 pooled analysis also showed no association. This project was updated in 2001, and findings were confirmed. A UK study by Bingham and colleagues reported positive associations when diet record was used. Authors blamed the earlier absence of associations on exclusive use of food frequency questionnaires. However, correlations between dietary and saturated fat assessed by diet records and questionnaires were high, and the confidence intervals in Bingham were too wide to conclude with certainty. An extended follow-up on Bingham and other cohorts using diet records and questionnaires showed no positive association, strongly refuting Bingham et al.'s conclusions.
Randomized trials are viewed as the best way to resolve uncertainty on the relationship between dietary fat and breast cancer. It is believed that randomized trials can create a wider difference in fat intake than prospective cohorts, and that randomized trials can eliminate confounding. The Women's Health Initiative trial randomized 48,000 women to a diet of either 20% total calories from fat or their usual diet. After 8 years, the difference in breast cancer risk was small and not significant. However, the reported difference in fat intake between groups after 6 years was approximately 8% of energy, not 14% as desired. Also, plasma HDL cholesterol and triglycerides did not differ from the intervention to the control group, indicating that the intervention may not have been followed closely. A study of 4,690 Canadian women randomized to a low-fat or usual diet and followed for an average of 10 years found a small and non-significant increase in breast cancer incidence in the low-fat diet group. In this study, plasma HDL cholesterol reduced significantly in the low-fat diet group, indicating adherence to the intervention. Participants in this study were chosen through intensive screening for likely adherence. A randomized trial conducted on women already diagnosed with breast cancer demonstrated a marginally significant lower risk of breast cancer relapse among those placed on a low-fat diet. However, those in the intervention group lost weight, which may have impacted the result.
So when it comes to dietary fat and breast cancer, there are many animal studies done in mice. Meta-analysis of diet and mammary cancer have been done, as well as differences in types of fats. In human studies, case control studies have been used. In Spain especially, they were able to show higher intakes of monounsaturated fatty acids, such as olive oil, showed a reduced risk of breast cancer. And when it comes to saturated fat, it has been linked to a greater risk of hormone receptor positive breast cancer, as well as breast cancer that is HER2 negative. There are alternative hypotheses as well, such as total energy restrictions, especially in Japan, where restrictions in energy intake during childhood tend to reduce adult height, which tends to decrease the incidence of breast cancer. And total energy intake can also modify the age of menarche. And by modifying the age of menarche, earlier menarche has been a well-established risk factor of breast cancer. Overall, studies have provided differing results when it comes to dietary fat and breast cancer, and there has not been any concrete evidence that dietary fat affects breast cancer incidence.
Current risk factors for the development of breast cancer include age, race, breast characteristics, reproductive patterns, hormone replacement, tobacco, alcohol, diet, physical activity, overweight, obesity, and insulin resistance. Foods that reduce the risk of breast cancer include those that reduce oxidative stress and lower chronic inflammation, such as fruits, vegetables, soy, cereals, and certain polyunsaturated fatty acids. Diets that increase risk for breast cancer also increase circulating levels of endogenous estrogen and pro-inflammatory cytokines. This includes saturated fat, salt, sugar, red and processed meats. More research is needed to understand the mechanisms behind the bioactive components of food, to understand the safety, efficacy, timing, and other drug-nutrient interactions. Research has shown prevention and early detection are key to survival. This prompted policy changes to include early mammogram screening programs, workplace and community interventions promoting active lifestyles, and individual weight management programs.